All right, in this unit, we're going to start talking about facilities, and we're going to start with primary care and outpatient. Here are our learning objectives. So as we'll see, growth in outpatient is a big dynamic in this particular facility. So first, let's talk about some definitions. And so the first is we're looking at primary care often. And so what do we mean by primary care? So we've talked about primary care, secondary care, and tertiary care. In this instance, we're talking about primary care as basic routine, continuous, coordinated. And so as we've said in our country, we don't put as much emphasis in primary care as other countries. We emphasize specialists a little too much, and that's one of the things that drives up our healthcare costs. So think of it as an approach rather than a specific set of services. However, also recall that we can have primary, secondary prevention, and sometimes tertiary prevention as well. And those are a little bit different when we talk about prevention as opposed to facilities that are at those levels. So we use the word outpatient care. And what that means is that you're not staying overnight. And so generally they take census in a hospital at midnight. And so if you're there overnight, then that's considered a 1 day of inpatient stay. And so we can also use this term ambulatory. Ambulate meaning to walk. And so these are services where you can walk in and walk out. And so sometimes it's also referred to as community medicine. And so one of the factors about this type of care is it's very accessible, very convenient. And so we'll see some examples of what we mean by that. Now, of course, the most basic outpatient service are physicians' offices. And so that's who we visit most frequently. So we may be getting physicals, we may be getting minor treatment, we might be getting checkups, we may be monitoring care. And so physicians' offices would be where the most frequent site of outpatient care. And so in terms of categories, physicians, as we say. However, hospitals also have a lot of outpatient services too. So we would consider those institutional-based outpatient services. And I'm going to show you some slides in a minute that kind of show what, how that's grown. And so we tend to think of hospitals as being places where people go and stay overnight, where we have intensive care, but there are a lot of outpatient services happening in a hospital as well. And one of the particular phenomena we're going to look at is ambulatory or outpatient surgery. And so I'll show you some data on that. But then there's also a lot of community-based outpatient services. So we might have the health department, we might have free clinics, that also serve the community. So as I said, if we look at primary care, secondary care, and tertiary care, now I'm not talking about prevention here, I'm talking about care. So we've looked at these in the past. Remember primary care, we've talked about here, but secondary care is short-term in duration. We've talked about our community hospitals there, and tertiary care is being that high-level care that happens in academic medical centers. So look at this percentage of uses. So 75 to 85% of our care is delivered in the primary care setting. 10 to 12% in secondary care, and not many people are using that tertiary care. So it's important stuff, but it's only for a small segment that need really highly specialized services. So as I said, some of the outpatient care, or much of it, is delivered in hospitals or institutional type services too. So that's me over there with my sprained ankle. And so part of where we can get that is in outpatient clinics. So there are a number of clinics that hospitals sponsor. Some of it can be rehab clinics. Cardiac rehab would be an example of that. If you have a heart attack, you may go in, you're admitted through the ER, you are either given some kind of care to clear up the blockage, and you could go home that day, or you may be admitted as an inpatient for monitoring. You may need more extensive surgery. But once you've recovered from the surgical part of it, they want you to do outpatient cardiac rehab. And so initially, if you've just had a heart attack, you're not going to want to start walking. You're kind of freaked out about you don't want it to happen again. So you go in and you do work on a treadmill and you're monitored. They look at you, you build your confidence. They see that you're not going to have another severe event. And so, so you can have your rehab in that kind of setting. It also could be physical rehab for knee replacements or other joint types of things. In addition, many hospitals have diabetes clinics. So as we've seen, diabetes is a debilitative disease and has a lot of side effects. A lot of people in our country have diabetes, so that many hospitals offer clinics to help diabetics try to manage their care. So there are these many clinics, as we say. But also, urgent care is probably what you're more familiar with. It can be, if we look here in Boone, it could be in a special outpatient setting, or it could be done as a fast track, if you will, through an emergency department. So what we want to do is get people with minor injuries, minor care, not in an emergency department that's treating heart attacks and crush injuries and really serious kinds of things, but yet get people the care they need in a convenient setting. Now, this last group here is community health education and support groups. So many diseases have support groups. It could be something like cancer. If you're going through cancer, you and or your family need some extra support, some extra help perhaps. And so there are special support groups for that. But there's a lot of community health education that goes on too in terms of trying to keep our community healthy. So as we say that we've got to be a little bit careful if we're running a hospital, because we don't want to be offering services that our physicians want to offer. We don't want to compete with our physicians. Remember, we're dependent on them to admit their patients to our hospital. Continuing on this, most hospitals have a lot of diagnostic testing and imaging that goes on. This may be actually a department in a hospital where they're doing it. It may be a freestanding diagnostic testing center. So probably many of you are familiar with this. You may need to get some lab tests. You may need to get some imaging. Or it could be cardiac scans. So there's a whole variety of facilities. So what we'll see oftentimes is we put these facilities on the first floor of our hospital to make it convenient so people can get in and out. And so as we said, there's also therapeutic services, so rehabilitation being one. But remember, we also talked about radiation therapy, radiation oncology. So much of cancer care is really done in the outpatient setting. If you're having radiation therapy or you're having chemotherapy, you're not getting that in the hospital for the most part. And so unless you've had some kind of surgery, some of that is even done on an outpatient basis. So one of my first projects was setting up a cancer center, and it was all outpatient. So you came in, one side of the facility was radiation therapy, and the other side was chemotherapy. Very what we like to call residential kind of architecture, setting, comfort. You're getting chemotherapy, you're in a big lazy boy watching some TV, etc., with some support people around you if you have those too. Several years ago at App Regional, they added that cancer center there. And then mental health, once again, or outpatient, drug rehab, etc. Once again, everything moving to the outpatient because it's cheaper. Once again, we got to be careful with these services because our physicians also may be providing those, and we want to be careful about being in competition with them. Now, this next slide, let's shift over to the emergency department. So one of the things I want you to see here, here's our bar chart, and it's telling us two different pieces of information. And so for test purposes, that's what I want you to be able to distinguish, these two different trends. So the blue line, the blue bars going up, that's the number of emergency department visits. And that is one of our issues and one of the reasons why costs are higher. Our emergency department visits are going up. We're doing too much care out of this facility that's really a high-tech facility and a very expensive facility. And so that's what you'll see in insurance. A lot of insurance products have really raised those co-payments in the emergency departments because they don't want you bopping in there to get your primary care. So they're trying to disincentivize that. Very, as I say, intense resources. Now, at the same time, emergency care itself is not a particularly lucrative care. So we see many hospitals getting out of closing their emergency departments. So we've got two things going on. The visits going up, the number of emergency departments going down. So you can imagine what is happening at the emergency departments themselves. So if you've been in one of these recently, long waits in the waiting room. I had to take someone to one a year ago. Long wait in the waiting room. Then once we got in the back, there were no rooms, no beds. And so they had a bunch of people lying on stretchers in the hallway. And that's where my friend was, lying in the hallway, waiting to, she actually needed an emergency procedure. So they were waiting for the physicians and everybody to get in, to take her upstairs to go do that. But that's where you stayed. Now, one of the other themes that we've talked about in this class is hospitals have become the kind of repository for all of everything that's happening in the community that nobody else can handle. So there are a lot of mental health issues that are also being brought to the emergency department. I was at a seminar and they estimated those to be about 10% of all emergency department visits. There are not enough inpatient beds. And so particularly with things like the opioid crisis, once patients come in and are stabilized, there isn't a place to transfer them, and so they stay in the emergency room until a bed can be found. And in fact, when I was at that emergency room a year ago, in the bed in the hallway next to where we were, there was a young man who was there escorted by a sheriff and who was handcuffed to the bed waiting a mental health bed. So as we say, because there are not as many emergency departments, more people are using emergency departments, many hospitals are reporting that their emergency department is either at capacity or over capacity. So as a system, that is a big issue for us. How do we get care moved to more appropriate settings. Now, in general, once again, here's a trend. The total hospital outpatient visits steadily rising. So we have really shifted from a system of inpatient care to outpatient care. That's good in many ways, but one of the challenges is the way that Medicare and others reimburse you, they want to get you out of the hospital. So it's good for many reasons that we'll see, but one of the challenges is who's going to take care of you back at home? So what's happening with Mima? Now that most adults are working, who's going to take care of Mima at home? Because we're not going to keep her in the hospital. So not only in terms of visits, but also the money, we see that revenue creeping up, not quite half, probably kind of close to about half now. So if you were running a hospital, about half of the money that you bring in is going to come from the inpatient side and about half from the outpatient side. So this is job security once again, because we need managers out there that can run these outpatient departments. Just a quick picture here. I just thought it was pretty. Diagnostic imaging. So we looked at X-ray, been around forever. That's kind of what those machines look like. And then MRI, here we are. We can see these details. We can look inside. And so that's what an image looks like there. And then PET scans show activity. And so, for example, one of the things that cancer cells or cancer tumors have more activity in them because they are creating their own blood supply. And so on a PET scan, tissue might look not colored, but then you'll have this brighter, highly active area. So here's just a picture of what not only the scans look like, but what the machines look like. MRI, some of you have had those. There's an issue with going inside this confined space, so they have more open MRIs now too to help people that are claustrophobic. So as I said, another major dynamic is the shift with surgery to ambulatory or outpatient surgery. And so this could be done in hospital surgery, or it could be done in freestanding surgical centers. So another of my projects back in the day was building and equipping and setting up an outpatient surgery center. And so you walked in, you parked out front, you didn't have to walk a long way. It was convenient, very attractive, looked like a house almost, beautiful colors. And then you would go back to the surgical suites after you had pre-op. So you're waiting, pre-op, surgery, and then post-op. And so some post-op was simple, and you're sitting once again in a lounge chair watching some TV. Others, we needed you, like for example, colonoscopy. Those can be done in those kinds of facilities too. And they're using some super drugs, and you're really out of it. And so you need to lay on a stretcher for a while. So as we said, these can be done in hospitals. This can be done in physicians' offices, or physicians open these facilities, but there also are some large corporations that also build these kinds of facilities. So why? Why this switch? Well, ambulatory surgery has lower costs than an inpatient admission. It's the turnaround time is faster. There's lower risk of post-surgical infection. As we know, the hospitals are where the superbugs are, so the extent that you don't have to stay there, that is in your best interest. It's convenient. You're in and out. You're parking out front. Patients like it. And so there's an overall greater efficiency, and the doctors like it, they're in and out. The patients like it, they're in and out. And so with the technological advances that we've had with laparoscopic surgery and other kinds of techniques, that we can do these procedures with minimal invasion and therefore lower anesthesia, therefore less impact, and you recover more quickly. All right, so if you look at the total numbers of surgeries, you can see this trend over time. Over half of hospital surgeries are done on an outpatient basis. We don't want to keep people in the hospital. It's expensive. There are superbugs there. It consumes resources not needed. So much of surgery is shifted to outpatient. So here's our pie chart. Let's take a look at that. So what are we doing outpatient? Now, as we said, remember we've got this aging population. Cataracts are a clouding of the lens in your eye. And so these procedures are done that just quickly remove that lens and put a new one in. And so with this aging of the population, a lot of people have this cataract surgery. And so that is the #1 surgery that's done on an outpatient basis. Other eye procedures as well, LASIK, Vizix, that kind of thing. As I said, we can do endoscopies, colonoscopies, so we can go in and scope in those facilities as well. And then some pain management done there where they're doing injections. A lot of those are done in physicians' offices now, but let's say you have a compressed disc or something like that. They might be putting steroids in a joint. And other orthopedics surgeries. So in terms of they're not doing hips and knees on an outpatient basis, to my knowledge. But if you have a tear in your ACL, MCL, that kind of thing, in a joint, they can go in and scope those and repair those on an outpatient basis. But eyes are #1. So another type of outpatient service that is also very important is home health. So let's say Meemaw had a knee replacement. We don't have to send her to a rehab facility after she's recovered from her knee surgery, which just takes a couple of days. And so we can send her home, and we can send in rehab to her PT and OT there at home. We can send in some people that'll help her bathe, give her some nursing care. And then now this homemaker service, here's the question here. All of these services are available. The question is, are they going to be paid for? So you can find people, visiting angels and things like that, that will come and do a lot of those activities of daily living, help you with meal prep, chores, that kind of thing, setting up your medications. But you must have a condition that dictates that you need this kind of help for this to be reimbursed. Another very profitable area is this durable medical equipment. Once again, assistive devices. So if you have this knee surgery, you may need a walker for a while, maybe a wheelchair, probably more likely a walker. You may need oxygen, depending on what's wrong with you. You may need a hospital bed in your house, particularly for something like hospice. You may need special commodes that are higher and that have bars on them so that you can have help with that as well. And so that's what we call durable medical equipment. They will be happy to rent this to you. Now, you've probably seen those TV commercials of those little scooters and things like that too. So Not that easy to qualify for that, but there is some demand for that too. So home health keeps us from being institutionalized, and that is a good movement. But I will say this, that with home health, while it's a wonderful idea, I've seen Medicare waxed and waned on what they'll reimburse for this. So it can kind of go up and down. Um, and so we as providers, we have to take a look at this and see what is the reimbursement. And there are clinical social workers, and that's part of what they do too. Before you're discharged out of the hospital, they have all these contacts, and they look at this kind of care that you might need, and they understand the reimbursement, and they have the names of the organizations that can help you with this. All right, our last slide here is just a couple of other facilities that we've touched on previously in class. And so public health is definitely an important provider in the community, and so particularly for immunizations, but they also offer another kind of preventive services and treatments as well. Also, there are publicly funded and voluntary clinics, including federally qualified community health centers that help that have sliding scales that help people with limited ability to pay, and free clinics as well. Now, free clinics are really helpful, but it's not like, I think some that I know of have limitations on visits, so it's not like you can just get all of your care there. All right, so I hope this helps give you an idea of what's included in this category and what some of the major trends are.